Welcome to Oncology for the Inquisitive Mind, a podcast that aims to demystify, explore, and provide a semblance of simplicity to the ever-evolving, complex world of oncology. A land filled with clinical trials, changing options for our patients, and ever-increasing survival statistics. As always, I am accompanied here by my illustrious co-host, Dr. Michael Fernando.
By far the least illustrious on a very illustrious podcast. It's even more illustrious than usual today, Josh.
It is, and do you want to know why? This is because we are joined here by a very special guest, Dr. Megan Crumbaker. Hi, Megan.
Hi, guys. Thanks for having me.
Thanks for coming. Thanks for being on the show. So, Megan, to give a little bit of a background about Megan, our special guest, she's exceptionally hardworking. She's brilliant. Just going to use all of the acronyms here, Megan, to introduce you. But to talk a little bit about Megan, she is a medical oncology specialist who specializes in genitourinary cancers. She's previously done a PhD for prostate genomics and currently heads up or works in the trial centre at the Kinghorn Cancer Centre here in Sydney, New South Wales.
Yeah, definitely don't head up the trials unit, but lead.
Sorry, Anthony.
Urinary cancers.
Wonderful. So I might get introduced with the first question, which is usually our origin section, Megan. For those that can't hear, Megan has a little bit of an accent, and she did her undergraduate through Rice University. I would love to know the story that led to you, I guess, doing undergrad in the States and then really coming across to Australia to do the rest of, I guess, your med school training, and I'll start with that so I don't steal all the questions, and then we can kind of ask from there.
So I'm American. I grew up in Florida, and I did my undergraduate degree at Rice University, which is a small university in Houston, Texas. And I took a year off between my undergraduate degree and starting med school in the States, and went traveling and met my now husband in Europe, who's Australian. So it was a cliched Kontiki love story. And after we met, I deferred my scholarship and slot in med school in the US and came out to Australia on a work visa just to see how we went, and then stayed. And that was back in 2005. So did med school at Sydney Uni and then have done all my training here since and stuck around because it's a bit more of a pleasant place to work in medicine than the US, and a lot less polarized politically these days too, which is a added bonus.
That's I guess very true, but you wouldn't have known that at the time from the politics perspective, maybe. No. My crystal ball didn't foresee that. No, I don't think anyone's did. But obviously, Megan, you have a huge body of work in GU cancers and specifically prostate, and your PhD was in prostate genomics. What was the light bulb moment, or what was the impetus for choosing that as a specific area of focus for your PhD?
Yeah, so I did my first 2 years of training at Royal North Shore, so advanced training, and then I did a genitourinary clinical trials fellowship at Westmead, and I really knew I liked genitourinary as a subspecialty. I think it really, between prostate, kidney, bladder, and testis, you get a really wide variety of prognoses, different demographics, and really different treatment types. So you really get to use kind of the whole arsenal that medical oncologists have. And so I was looking for a genitourinary PhD. I was hoping to avoid a PhD if possible. That's why I did the third clinical year, which I think is great from a clinical point of view, but it didn't do anything to help me avoid doing a PhD. But basically, I was just looking around. I was trying to find some place where I could do a PhD, where I could get some clinical work and do a genitourinary PhD. And I met Anthony Joshua, and he really appealed as a supervisor. And I could do clinic with him, really busy GU clinic. And basically he kind of was like, the world's your oyster here at the Garvan. Go and speak to a few different people and see who kind of floats your boat for doing a PhD with them. And he mentioned several names, and I went to meet with a few different people. And that was back in 2016. And really genomics was really, and especially in prostate cancer, but really in all tumor types, personal medicine and sequencing, and everything was kind of the hot topic for everything, but just emerging because it's quite expensive and not necessarily accessible. And so it did seem like a good idea to add that skill to my toolbox, I guess, tool to my toolbox. And so I met with someone, my other supervisor, Vanessa Hayes, who did prostate cancer genomics as part of, well, she's a genomicist and does quite a few different things, but prostate cancer is one of them, and had a chat to her, and I wanted to make sure when I did the PhD, I really wanted to make sure, I'll go into this a little bit because I know a lot of oncologists or trainees are thinking about PhDs and whatnot, and so I'll go through my thought process. But basically, I wanted to do something that expanded my skill set in something that was really topical at the time. And so to me, genomics was, and GU particularly, because immunotherapy wasn't really showing success yet, and still isn't really in prostate cancer. GU can't, a lot of the GU, they hadn't really been tested in a lot of the GU cancers yet. And I was looking for a combination kind of lab and clinical PhD, because if I put all my eggs in one basket and was relying on a clinical trial to recruit and everything, it really felt like that PhD could be problematic if that trial closed down. I knew of a few colleagues that had that situation, and they, adapted and whatnot, but it seemed good to kind of develop some skills where I kind of looked behind the veil of what happens in the lab and how this genomic report gets spat out, which was really enlightening. I think a lot of people take for granted that information, and how black and white it is. And I also wanted us, with that combination of lab and clinical, I also want to make sure my lab supervisor had supervised clinicians before, because it is its own kind of kettle of fish, because, I'm a bit older than the average kind of science PhD student at the Garvan. I have done a lot in my career already, and also I was going to be doing part-time clinical work, which is always going to have me back and forth, even on my non-clinic days. You're going to get calls and whatnot. So I wanted to have someone that would understand that situation. And so that's what I was looking for when I was doing my PhD, because really when you're looking for a PhD students are cheap labor. You're really popular. You kind of think, oh, who will take me? But a lot of people are going to want you. So you can really kind of tailor things to what you're looking for if you kind of know what you're looking for, I think is a thing. Not really a light bulb moment exactly. It was really a kind of slow evolution of figuring out what I wanted by talking to other people and realizing I had to do a PhD to get a metropolitan job,
Yeah.
which I'm glad I didn't expect, but at the time.
It's always daunting, I think, when you look, you've already done, 10, 15 years of study / work, and you're like, great, here's another potentially 4+ years trying to do a PhD, which is a new set of skills. You're like, I finally, maybe not master, but I finally got to a point where I can, clinically, I'm quite proficient, and now you're kind of back to being that student.
Absolutely. It was there's a lot of uncomfortable parts of as being a PhD student. And I think some of them are more uncomfortable having gone through and kind of, in theory, kind of gotten to be a specialist and feel like I know my stuff, and then being thrown back into the deep end with a completely new set of objectives that I had to learn. But it did mean that, some people do a PhD just to tick a box, but that's never been my style. I wanted something that if I was going to do it, I wanted to come out with new skills, new knowledge. And with the genomics, what I was hoping to do, and I think, just having helped a lot of collaborators recently and done a few interviews, helping some researchers and whatnot, what I wanted to do was be the kind of bridge between the scientists and the clinicians, because I think a lot of times the two parties are saying the same words but meaning completely different things, or the vision that the scientist has for what they're studying and how it will translate into clinical practice is completely different from the reality of what might happen, or vice versa. So I wanted to kind of I was never going to get as, I'm not a computational biologist. I'm not I'm not a full academic science between the two to help make it so really important translational work can make it into the clinic. It can kind of span that gap in the knowledge between the two different parties if I can help facilitate that.
Yeah, that's a really nice way of looking at it. And I think the question I had before we move on from, I guess, the PhD perspective, what is the best skill you learned? What's the thing? I mean, I understand what your objectives were, but what's the skill that you kind of like,
Yeah.
I took that from my PhD. I am, yes, it's a hard path, but I am just, it kind of satisfy your need for like, I did this and I'm actually better now than I was.
In genomics terms, I think the biggest thing is I understand when I order genomics test, whether it's genetic or somatic, I understand what I'm looking for in that test, and I understand the limitations of that test. And I also understand what the report means when it comes out. And that sounds like a really basic skill, but it's actually a skill most clinicians don't have. So I think understanding the limitations. So I think a lot of times with genomics, people look at the gene list and say, oh, these genes are relevant. But for prostate cancer, it's not just the genes, it's not single nucleotide variants. It's actually copy number alterations that are more important. And a lot of the commercial assays don't look at that. And that's really important. So certain cancers, it's not just about the gene list. It's about what cancer you're looking at and what are you looking for. So when you're ordering the test, you really need to know what those limitations are. And most clinicians will just kind of order the test. And then it's also so I think it's kind of understanding what I'm ordering and what the result is, but also understanding better how they explain it to the patients, and what their limitations are, because I think, they oftentimes go in this assumption, oh, you're testing my gene, so if it comes back in negative, or like say for genetic, my hereditary risk is nothing or something like that. Figuring out ways to explain, we're only testing a limited number of genes. We're not even testing all the genes, and things like variants of uncertain significance that come out, being able to explain that. And I think a lot of GU oncologists are now hadn't appreciated how commonly they're going to get these variants of uncertain significance and what that actually means, because now we're doing a lot more BRCA1 and BRCA2 testing for prostate cancer, for PARP inhibitors, and for clinical trials, and we're getting these gray zones. So I think a lot of people initially, when we were talking about personalized medicine and everything, thought, okay, I'm going to order this test and I'm going to get, yes, there's something I can target, or no, there's not. And in fact, more often than not, the answer is, yes, there's something, but we don't know if it's targetable or relevant or not. And that's because the knowledge is still accumulating. So I think that's the biggest skill, is understanding how to interpret what the genomics test is testing and what that result means. And I think that's been useful, because I think I've had a lot of emails from different GU oncologists kind of asking questions. They've gotten some results and whatnot, aren't actually sure what to do about them. And so being able to help with that has been really good. And then also being able to kind of help the interpretation with my own patients, because I'm doing a lot of genomics testing, and not kind of fobbing them off with a quick kind of glossing over answer. So they do truly understand what's been tested and what questions have not been answered by that test.
Absolutely. It really does sound like, from our level, Megan, it's sort of like us getting a call from someone in ED, and they're asking about prognosis of someone who has an EGFR mutation in their lung cancer or something, and having that insight, but obviously at a much more complex and involved level, which is fantastic.
Yeah, I think the thing is like the EGFR mutation, those activating mutations, there's like really specific exons and really specific mutations that we know are pathogenic. And I think that's great for those cancers. And like melanoma, we've got the BRAF, and we've got specific mutations like the V600E. But in prostate cancer and a lot of tumors now, we're doing a lot of research only kind of assays, and we're doing a lot of testing, and it's kind of, looking at big swaths of the gene. And so you're going to get a lot of mutations that are completely irrelevant, and you need to be able to interpret that. But also, when you're not looking for a very specific mutation like you are, say, in melanoma, BRAF mutant melanoma, or even the limited mutations in lung cancer, you're going to get a lot that are still unknown. I mean, BRCA1 and BRCA2 are really big genes, so you get a lot of mutations, and we don't know whether there's a lot that are still unclassified, whether they're benign or pathogenic or uncertain.
Well, I think we've got a number of questions on BRCA. You probably answered all of them already, but I'm sure we'll come to that a bit later. But obviously a huge area of research and developing research. But I guess one thing that you said, Megan, that really struck me is that you sort of looked at that as a pathway, as yourself and Josh have said, to add to your skill set. And so leading on from that is you also went to Princess Margaret or underwent a Princess Margaret Education Fellowship. And was it a similar sort of thought process where, you wanted to add to the, as you said, the toolbox that you had available?
Yeah. So the Princess Margaret, that was about 3.5 to 4 months that I did during my PhD, and that was funded through a Beverly Alt fellowship that we're lucky enough to have locally at the Garvan in Kinghorn. So I did an application, and it gives you some funds to basically fund kind of the travel or whatnot. And so that was in Trevor Pugh's lab at Princess Margaret in Toronto, and he particularly does a lot of circulating tumor DNA, not specifically in prostate, but in he's a humongous lab, and they do a lot of different tumor types. But they did have a project that already had samples that I could utilize when I went over there, because 3 to 4 months is not a long time to achieve much. You need to make sure the ethics are in place and there's samples and things like that. So I was going over there because the work I was doing at the Garvan was more whole genome sequencing and actually optical mapping. So technology that's being used, but not really practical for, it's expensive and pretty cumbersome. So it's great for research, but not great practically for most clinical applications. And so, ctDNA is emerging as a major thing. And in prostate cancer, where you get a lot of bone metastases that aren't easily biopsyable, and the DNA that comes out is pretty rubbish a lot of times, it was something that seemed really important to learn more about. So I kind of understood the spectrum of different DNA sequencing and assessing technologies. And so, and basically it was leveraging one of my supervisors, so Anthony Joshua's pre-existing contacts. And I think oftentimes for travel fellowships, the best way to do it is to leverage some of your supervisors or previous consultants contacts. So it was partly that relationship was there, so it was easier to kind of get my foot in the door there. It was a technology that I thought was important to learn in a new environment, because even if you can learn the same thing. I mean, we know in medicine you go from one hospital to another, and even like how you prescribe an iron infusion is different. You think that should be pretty black and white. So going someplace different was good. While I was there, it was mainly lab, but I did do just observership. It wasn't enough time to really worry about the paperwork and visa to be able to do a clinical actual work. But I did observership in the clinics just to see how things were done over there, which was actually really interesting as well.
That's amazing, Megan. I think you're very much at the forefront back in 2016 thinking about ctDNA, and it's in almost every study these days to some extent, looking at it and the applications moving forward. I might jump across to the wisdom and I guess the pearls section that we like to chat about on our interviews. And I think the first one's a bit of I don't know if it's a hard question or a controversial question. Prostate-specific antigen, we're talking about prostate cancer here, used as a screening tool in the mass population. In Australia, there's been a lot of, I guess, discussion, especially in the older populations, whether people should get routine screening. And I notice that a lot of the time it's the oncologist, you don't sort of hear the oncologist side of it. And I guess I'd love to hear what your thoughts are from just a routine screening perspective of using PSA.
Yeah, I guess the oncologists don't weigh up into it too much because we tend to treat more advanced and metastatic patients. So they've already kind of gone through the screening and localized or not localized. So it's generally the urologists that weigh in more, and a lot of times their opinion is probably more relevant. I think so the US guidelines, the European guidelines, as well as the Australian guidelines, the GPs, is that it should be an individual decision. And they do give an age range, but they do say, that's not restrictive, that you shouldn't test outside of that age range, but it's a guideline. And then they also say that GPs shouldn't really be doing the rectal examination that as a screener. And so that the rectal examination has also garnered some controversy from urologists thinking that it's still a valuable tool as well. And it's not, and certainly the guidelines aren't saying don't do it, but they're saying GPs should be doing, kind of focusing on a population, an age group. I think it's 50 to 70. That if they're treated for that prostate cancer, it's still going to be meaningful as far as kind of their longevity, if it was a localized cancer, and also kind of referring for the more specialized tests after that. And I think the main thing, I think I guess there's two things. I think PSA is really valuable, but imperfect test. So if it was a perfect cancer test, it would be positive if there's cancer, and negative if there's not cancer. And clearly that's not the case, because if you've got a prostate, you're going to have a PSA level. And so it's a very flawed test. And I think putting it onto GPs to have that individual discussion, I think it is a better approach than just blindly doing it, because there's a lot of men that you wouldn't be doing a prostate cancer biopsy on, even if they had an elevated PSA or whatnot, because you just wouldn't be treating their prostate cancer. And then there's a lot of men that, and if they're in their 90s or whatnot, then what are you necessarily achieving if they've got a localized cancer? You're not going to do prostatectomy, and you're not going to do, intensive radiotherapy. So I guess you got to think about the goal of screening, and it's to pick up a localized cancer. And a localized cancer is going to have a really good prognosis anyway. And so whether you do something or not in prostate cancer. So if you're going to pick up a cancer that's probably going to behave for the next few years to several years, then should you be bothering to pick up that cancer, I guess is the question. And there's men where the answer is no. The tricky thing is there's plenty of 60-year-olds that have a lot of comorbidities, and I've got plenty of 90-year-olds that, not plenty, but I've got 90-year-olds that are chemo candidates. So it does need to be an individual discussion. And I think the GPs are under so much stress, especially after COVID, and so under-resourced. I think we just need to make sure that the educational tools they get to have that discussion are easily accessible, and probably some resources that patients can read on it that have been put together by, urologists and GPs together on the point. And hopefully those exist. I know there's a lot of resources, but hopefully there's something that's been developed that's quite simple. But not being a urologist, I'm not sure. But I'm not sure that there is something. But it's a very nuanced discussion, because it needs to take into account family history and fitness, and there needs to be an explanation of PSA not being a perfect test and whatnot. I mean, we all have those cases that come and say, oh, my GP didn't do my PSA for 2 years, and now I've got this terrible metastatic cancer. And I guess, those are the nightmare cases, but you hear the same about colonoscopy, so all screening tests, you're going to miss some cases, but you've got to be pragmatic. I mean, you're not going to biopsy. The biopsy is not comfortable. A lot of men aren't going to agree to it. And then the MRI is quite costly. The biopsy is costly. The gold standard is a perineal biopsy, transperineal biopsy. So you do have to be practical when the bucket of money is finite. But I think it's tricky. That's a lot for a GP to cover in a short consultation in a man that probably has other things that need to be looked at. And so I think the guidelines are correct, but we just need to make sure we're resourcing the GPs for them to be able to kind of make those calls if it's going to be a case by case basis and do it easily because they're just under so much stress from a workload and resource point of view already.
As with everything, it's much more nuanced than it might seem from certain points of view. So that's a very comprehensive answer, Megan. Thank you. We are recording this episode towards the month of November, or Movember, as it is commonly known in prostate cancer circles. And I guess it is one of those cancers that is very present in the minds of the general population. But it has fallen, for want of a better phrase, fallen by the wayside in that it hasn't been had those visible leaps forward. I'm thinking predominantly with immunotherapy that some other cancers have had. But that's not to say there's nothing exciting happening in prostate cancer. So, I mean, from someone who's really at the cutting edge, Megan, what from your perspective are the most exciting developments that we've had in prostate cancer over the past few years and into the future?
Yeah, so I mean, even since I was a trainee, so since 2015, we've gotten abiraterone and enzalutamide for castrate-resistant disease. We've had those and other similar drugs move into the hormone-sensitive space, but unfortunately, we're still waiting the PBS access. Fingers crossed, apalutamide comes on soon because it's been approved by PBAC, and that's greatly improved outcomes for men. But I guess the bigger things coming through are the radionuclide therapy, so lutetium PSMA. And that's a great treatment for a large proportion of men because it's low toxicity, and you have a screening test with the PET scan to kind of judge the likelihood that they're going to have a good response to that treatment. But again, the big thing is access. But the PSMA, the radionuclide treatments, they have a lot of appeal, but there's still room for improvement on kind of duration of response and getting those men who don't have PSMA expression, figuring out what we can do for them. So the radionuclide treatments, and then I guess there's a targeted therapy. So we've got the PARP inhibitors, which, I think for the proportion of men that have a mutation, which is a relevant mutation, you're looking at kind of 10 to 15% of men with castrate-resistant prostate cancer. It's another option. And, there's evolving data to say maybe we're going to be using it in all comers as well, with PROPEL and TALAPRO-2 having positive findings in all comers in the castrate-resistant setting in combination with an androgen sensitizing androgen signaling inhibitor. So a lot of evolution there. And then with that, we've also got the other targeted drugs like we've got the AKT inhibitors and some cell cycle targeting agents coming through that, have shown pretty good success in breast cancer. So there's a lot, it's a very active area of research, and there's a lot of therapies coming through. I'd say I'm most excited by the radionuclide treatments like the lutetium PSMA, just because the toxicity is so low, and there is the, diagnostic side of doing the PET scan to be able to see what the PSMA expression's like, and somewhat have some assistance in predicting whether that's a suitable treatment for the patient or not. But I think we're getting spoiled for choice, but there's a lot of these treatments that are only benefiting a smaller set of men, or we're not able to access them unless it's on a trial or the patient self-funds it. And so I think that's where we're really falling down as we keep, a lot of new things are coming through, and we're excited by certain things. But, the lutetium PSMA, there's been an application to get it funded through the government, and that's hit a lot of obstacles so far, even though it's a treatment that has been around and has some has randomized phase 3 and a randomized phase 2 study data to support its utility.
Yeah, that's really interesting, Megan. The barriers in Australia, I guess, from the PBS, especially when there's known benefit, I think, with robust evidence to support more lines of therapy. I know in breast cancer we have multiple lines, and in prostate you have a couple, and then you're like, okay, we need to start really looking at a clinical trial after, 4 or 5, I guess, lines. One of the questions, or I guess I've always struggled with, is how do you choose between the different, I guess, modern day sort of anti-androgens? I'm talking about the enzalutamides and the abiraterones, and like, how do you kind of figure out what's best in which circumstance?
Yeah. I guess the big players, right? I mean, we've had abiraterone and enzalutamide since I think about 2015. And we've got access to that in the castrate-resistant space, but we know the efficacy is much higher and the outcomes are much more improved if you move that into the hormone-sensitive space. And so with that, really, I think people got excited by enzalutamide not having to use the steroid. And so I think when Enza first kind of became available, a lot of people did switch over to enzalutamide. It's a bit like in kidney cancer where a lot of people switched from sunitinib to pazopanib, but then a lot of people that are specifically niche kind of GU oncologists have switched back to preferring abiraterone. There's been some studies, but they're all, low level evidence that maybe Enza is a bit more potent and better to use kind of first. And abiraterone is. And I think what I think efficacy wise, there's probably not too much of a difference between the different ones. I probably still favor abiraterone, but from a side effect point of view, if we're talking strictly abiraterone and enzalutamide, I think most people find that the cognitive side effects and the fatigue side effects are a lot more common in enzalutamide than probably you get the impression from the clinical trials would kind of lead you to believe they are. It is the fatigue and the cognitive impairment is dose dependent, and enzalutamide is one of those drugs that the maximum tolerated dose model of dose finding resulted in enzalutamide being way overdosed versus what an effective anti-cancer dose would be. So most GU oncologists are happy to drop the dose and not worry about a compromise in efficacy for enzalutamide. But I just have there's a lot of men that get that fatigue and really fuzzy cognitively. And they're already feeling that with the ADT that they're on in the long term. So I tend to not use enzalutamide in most cases, and my preference tends to be abiraterone unless there's a reason not to. Expanding out though, apalutamide, daralutamide, apalutamide hopefully is going to be accessible for hormone sensitive disease. Apalutamide, you get like a 1 in 5 to 1 in 3 men get a rash. That's annoying. And you don't really see that so much with the other drugs, but I will be using that if it's accessible in the hormone sensitive setting, because efficacy wise, it's great. And generally, they are well tolerated and the rash is manageable, but it's just kind of annoying compared to the others. And daralutamide, you don't get the cognitive side effects, you don't get the fatigue, and you don't get the cognitive impairment that you see with enzalutamide and apalutamide, because it's configured differently and doesn't cross the blood-brain barrier. So kind of if I'm choosing between Enza, Apa, and daralutamide, and I was able to access them equally, I'd go for daralutamide because it's in theory a little bit more potent and the side effects are less. But when you're talking about accessibility wise right now, we're going to be able to access hopefully APA in the hormone sensitive setting soon on PBS, and they're all good enough drugs that I'm not going to worry if that's the one that I've got access to, that's the one I'll be giving if I don't have a trial access for anything else. And in the castrate resistant or all things being equal, in the castrate resistant setting on PBS, I tend to favor abiraterone if they haven't had one of those agents before.
Yeah, there's a lot of sort of subtleties in there, I guess, and a lot of clinical considerations, as you've said already multiple times. It's an individual case, but that's really interesting what you said about the enzalutamide and it being overdosed. I wasn't aware of that. Look.
Yeah. So, they went up to a higher dose, and just the way these phase 1 studies are designed for dose escalation. You go up until the maximum tolerated dose when a certain number of people get toxicity. So you go up until a certain number of toxicities, dose-limiting toxicities occur, and then your dose that you choose is the next dose level down from that. So it has nothing to do with the minimal effective dose. It's really the maximum tolerated dose, as MTD in phase 1, stands for. So you're getting a lot of drugs where you're giving a lot more drug than you need for anti-cancer effect. And enzalutamide, I'm not going to go into the ins and outs of it, but far more clever people than me, like Howard Gurney, who has a really strong pharmacology background, very strongly believe that and have evidence to support that enzalutamide is one of those ones that you're not going to compromise efficacy if you drop the dose, but you're certainly going to reduce those side effects quite significantly. So I don't start a lower dose up front for most men with enzalutamide unless they're particularly elderly or are going to have drug-drug interactions, because enzalutamide, again, one of the downsides is it has more drug-drug interactions than abiraterone. But I don't hesitate to drop the dose if I run into those side effects. The hardest thing is convincing the patient to drop the dose even when they're quite miserable, because of course they're worried it's going to compromise the efficacy. But it's one of those drugs, in kidney cancer, you need a dose to toxicity with those TKIs, but enzalutamide, I'm not worried. I don't think they need to have toxicity to be on an effective dose.
And you mentioned darolutamide as well, which I believe at this point in Australia is only approved for castration-resistant M0 disease. Now, I've been told by, I don't know if you've met Ian Davis, but he once told me very, very strongly that with the advent of PSMA PETs and better imaging and better imaging modalities, that M0 CRPC is much less common. I believe he used the word extinct, but much less common than it used to be. So I guess my question is, how frequently do you see M0 castration-resistant prostate cancer? Why isn't it just called? Is it a different sort of disease entity to properly metastatic disease? And I guess do you know why they approved darolutamide just for that?
So the reason why darolutamide's so we've got to think M0 defined by, so prostate cancer discussion we always have to have. Discussions are really long in prostate cancer consultations. I think everyone thinks prostate cancer is easy, but basically there's conventional imaging in prostate cancer, which is a CT and a whole body bone scan, and then you've got PSMA PET. And our trial data in prostate cancer is all based around conventional imaging. And so on conventional imaging, and that's what the data that we use to make our decisions is based on. All trials, it's evolving a bit more now that PET scans are more readily available overseas. But you can't be in the Australian bubble and think that PSMA PET has not been as easily accessible overseas, or not accessible at all for as long as it has been in Australia. So CT and bone scan has still been the standard to image patients. And so on the trials, it's CT and bone scan. And so for M0 CRPC, you're talking about on conventional imaging. So yes, you're going to get a lot of men that have metastatic deposits that are picked up on a PSMA PET scan that aren't picked up on a CT or bone scan, because the PET, is a different modality. It's going to be more sensitive as long as the patient has PSMA expression. And the majority of men in prostate cancer, for most phases of prostate cancer, if it's an aggressive prostate cancer, are going to have high PSMA expression. So yes, M0 disease does exist both in PET and conventional imaging, but there's far more men that are going to have it on conventional imaging than PET. So when you look at M0 CRPC, you need to be judging to access darolutamide. I think there's darolutamide, enzalutamide, and I think apalutamide. They've all got M0 CRPC indications on PBS. Out of those, I favor darolutamide because of lower toxicity and good potency on the androgen receptor. But when you're looking at that, you need to be thinking about conventional imaging. So yes, you could have 100 spots on a PET scan, but if they're not showing up on a CT and a bone scan, you can access that drug for that purpose. And the reason why they're improved in that setting is because that's where the randomized phase 3 data has been established. So those studies were recruiting back in like 2013, 2014. So those studies have had positive outcomes. And so, that's why they've gotten approved on PBS for that indication. Whereas some of the other studies in the hormone sensitive setting, they have some of those studies are more recent. And that's a bigger pot of money that would be required to pay for those patients. So even though there's efficacy in those arenas, I think basically there's the kind of health economics of funding in that setting. Whereas I think the health economics was satisfactory in the M0's CRPC setting. But there's going to be men that you do know where their metastases are based on a PET scan. But the question is just because you know where they are, does that change the fact that they need systemic treatment or not? And you'll have some men that you find, one spot on a PSMA PET, or maybe a couple, and they've got a slowly rising PSA. They've had a really long period between the time they had maybe definitive prostatectomy or radiation to the primary and relapse. And you get the feeling that they've got some indolent disease, and you see, some oligometastatic disease on a PET scan. Well, maybe that person doesn't need systemic treatment, and you could get away with giving them oligometastatic directed treatment. But there's a lot of men with M0 CRPC that, even though you know where the spots are on the PET scan versus the conventional imaging, their PSA is going up steadily enough. That's just the tip of the iceberg. I mean, to show up on a PSMA PET scan, the area needs to be at least 2 and probably about 4 millimeters to really show up reliably on the PET scan. So there's a lot of cancer that you're not seeing on that PET scan. So to do oligometastatic treatment, if they have a really rapidly rising PSA or even a moderately fast rising PSA, you're just it's like, it's funny. Everywhere seems to have whack-a-mole. I thought maybe it'd be an American reference, but it'd be a bit like whack-a-mole. You're going to hit one spot and then another spot's going to go up if you do oligometastatic directed treatment in that patient. So you should be giving them drug. And so if you can get, a drug in that setting where we used to not be able to, then you should use it. And I have no complaints about, yes, there's the semantics of M0. Is it really M0? No, it's probably not M0. But in the end, it's M0 on conventional imaging for the purpose of PBS. That population does exist. It's not a huge population, but it does exist. And it gives them access to a drug that we couldn't access otherwise. So it's not a bad thing to have that terminology.
No, definitely, Megan. I think it comes down to that, the nuance, as you said earlier, the nuanced approach to prostate cancer that all of the conversations in our clinic seem to go for quite a while, because it's not as straightforward as starting versus stopping something. One of the older drugs that I guess I saw used previously a fair bit was Kosidex or bicalutamide. Where do you see, with the advent of, I guess, a newer generation of really effective medications in the castrate-sensitive space, along with the castrate-resistant, where do you see the role of the older generation of, I guess, bicalutamide moving forward?
Yeah, it's interesting because the control arm on a lot of these hormone-sensitive metastatic studies, so like Enzamet, the control arm was ADT in combination with bicalutamide. But a lot of people were kind of like, well, in practice, I wouldn't actually use bicalutamide just on an ongoing basis in that setting. A lot of oncologists would kind of use potentially the bicalutamide for the flare phenomenon if they're using an LHRH agonist. And then they would stop it and then only reintroduce it once the patient becomes castrate resistant and the PSA starts going up again. But it was in the standard of care arm of a few of these hormone sensitive trials, namely, the Australian ANZUP-led Enzamet study. And I guess when you look at the data for using, because we still don't have PBS access to these newer agents in the hormone sensitive setting, So I guess the question is, do you use combined androgen blockade with Cosidex in that situation? But I think you could find evidence for and against using it if you're only giving the patient ADT monotherapy and can't access, they're not suitable for docetaxel, and you can't access a novel anti-androgen. You could justify either way. I think in Enzamet, the big thing was, I think they were giving a tablet in one arm, so they wanted to give a tablet in the other, and there wasn't, compelling evidence to say either way whether or not you should or shouldn't use Cosidex. There's data for both, but with Cosidex, I tend to only use it if I'm using an LHRH agonist to cover for the flare. So I tend to it comes in a box of 28. So I say about 2 weeks before you get the LHRH agonist, have it, and then have the ADT, and then have it for about 2 weeks after. Then the box is going to run out and you can stop it. And I don't keep it going. But there's some men that get, great response to ADT. And then their PSA starts to kind of simmer upwards after that. And I still will use Cosidex in that situation where we've got kind of a slowly simmering PSA. To want to do potentially something, and Cosidex tends to be pretty low toxicity. It can exacerbate hot flushes, and it does cause more gynecomastia than ADT, which some men find, one, aesthetically displeasing, and two, it can be quite tender. But you can give radiotherapy to the breast tissue if it is a big problem. But there is a subset of men that get a really great response out of Cosidex and can go on and on and on and on with it. And we know that because, before we had access to these drugs, we had lots of men on it. And so when I'm talking to my men about their metastatic prostate cancer, I'm talking, I tell them it's a marathon, not a sprint. And the more, because we can't cure them, the more treatments we can string together sequentially, obviously nowadays we're putting a lot of the treatments together, but doing multimodality treatment or at the same time. But the more treatments we've got up our sleeve to string together, the longer hopefully we keep their symptoms under control and their cancer under control, and hopefully the longer they live. So, I don't think Cosidex is necessarily, there's a lot of men where their PSA, it can turn their disease is very aggressive. And in that case, I wouldn't necessarily stuff around with Cosidex for very long, or maybe not at all, if I had a trial alternative, or I might just put them directly on Abi or Enza. But there's a lot of men whose PSA kinetics are quite slowly rising. And so if you can use a relatively well-tolerated drug and still keep those other things up your sleeve for later, it's not a bad situation. So that tends to be kind of where I use the Cosidex.
There really does seem, and you're really giving a great illustration of the art to treating prostate cancer, as well as the science in terms of these sorts of subtleties. I guess you mentioned in the context of your prostate genomics work as well, but one of the things we really wanted to ask as well was in terms of BRCA testing. You mentioned it's present in around 15% of the patients with prostate cancer, but at what point do your metaphorical antennae go up, and do you think, this is someone who I really need to look at this very closely? Do you have any sort of clinical pearls about requesting the test? Obviously, you have the expertise to actually look at the results and interpret them. But for us plebs who don't know that yet, at what point should someone sort of think of requesting that test?
We are very lucky at St. Vincent's where we can get access to testing quite easily. And so the international guidelines are you should be doing genetic testing, so germline testing on all metastatic men and certain high-risk localized prostate cancers. You should be testing a certain panel of genes, including BRCA1 and 2, but there are a few others, in all men with metastatic disease. And so if there's a way for you to access that, then all men should actually be having that, because there have been studies that have shown that, family history and age and whatnot don't necessarily predict who's going to have those mutations. And now that it's not only relevant for the family members, it's also relevant therapeutically for that patient. It is really important. But a lot of places can't access that testing. They're not, it's not on Medicare rebatable. And getting access to genetics counselors is not easy at a lot of centers. So we're really lucky in that regard. But if you can access it, because there are a lot of clinical trials that are doing pre-screening and whatnot, if you can access it by referring to a clinical trial, I really just urge to just do it as soon as you can. On MBS, on the Medicare benefit scheme, you can access BRCA1 and 2 tissue testing once in castrate-resistant prostate cancer, and you can test it once. And so most people, I think, usually you're going to be using the archival specimen. There's a downside to that in that as you get expose the patient to more treatment, they can pick up more somatic mutations. And so there can be some men that if you use the archival kind of primary prostate tissue, you're going to miss some that have actually accumulated a new BRCA mutation since that time. But getting tissue in prostate cancer is difficult. But I think a lot of clinicians, and I think it's a reasonable strategy, are testing once the patient becomes castrate resistant and accessing that Medicare benefit scheme funded BRCA tissue test at that time. And that's because there's a couple month turnaround time. And a lot of times that's when the patients are oftentimes getting either AbbVie or Enza. And you can only access the PARP inhibitor once they have had one of the novel androgen signaling inhibitors. So you're kind of thinking one step ahead if you get the testing then. If they don't have tissue or the tissue fails, then Medicare will pay for a germline test. And so you're going to miss those that have picked up a somatic mutation, but you are going to, it's better than nothing. You can get a germline test in men who you can't get tissue testing on. But so practically speaking, if you're trying to access it just through, the available options through Medicare, you're going to wait till castrate resistant setting, and it's going to be a tissue test, and it's going to be particularly for BRCA1 and 2. In actuality speaking, there are so many clinical trials for prostate cancer that are doing pre-screening where you get a full foundation medicine report, even if you're not eligible for the actual trial. And there's a lot of those in the hormone sensitive setting space. We've got multiple. We've got Amplitude, which is using a PARP inhibitor in patients with certain DNA damage repair defects. And so they get a full foundation medicine and an 85 gene germline panel, and we get the report for that, whether they go on that trial or not. So only 10% of men are going to, or probably less because that's hormone sensitive, are going to have the relevant mutation, but we're getting that information for every man that we pre-screen. So really, I encourage people to think about referring to trials to get that access. But if you don't get it, or you've got men that are further down the track who have already, are already in the castrate resistant setting, I think as soon as they're castrate resistant, you should be thinking about whether to get that test and whether or not there's some fresh tissue you could get to make the test less likely to make sure that the test is more likely to be successful, because there's a pretty high failure rate right now with the BRCA testing from archival paraffin embedded tissue. And if you get fresh tissue, you also, so you have a higher chance of getting an actual result from the test. And you're looking at that tumor in its current state. And so if there's been some new somatic mutations that have been picked up, you're not going to miss those by using archival tissue. But I think in actuality, most people are still using archival tissue because that's just what's available.
Yeah, I think, I guess volunteering for secondary biopsies can sometimes be very difficult to convince people of with good reason.
Yeah, and the DNA you get out of bone is not going to be great. So it's going to have a high failure rate too. So really you're looking at patients with soft tissue. If you've got like a soft tissue kind of, node, and the more PSMA PET we're doing, you're finding a lot more nodes in a lot more places than we ever knew. So like I've had a lot of patients with supraclavicular nodes that are accessible. So as PETs, patients are having PSMA PETs aren't funded in the metastatic setting, but they are being done in a lot of places. So if you do see that soft tissue that's accessible, then it's a worthwhile consideration. But if they've got bone only disease, then using the archival is perfectly fine. And and probably going to at least yield a result rather than a failed test, rather than going for a bone biopsy.
My question is, where do you see immunotherapy's role in prostate cancer in the future?
It's funny because prostate cancer was one of the first, to have like, quote, immunotherapy, but it wasn't these immune checkpoint inhibitors. It was Sipuleucel T and Prostavac. But after those early, and those were pretty modest successes, it's been pretty poor. The outcomes with the more modern immune checkpoint inhibitors in prostate cancer. There is about 5% of men who do have mismatch repair deficiency in prostate cancer, and the literature has evolved to incorporate prostate cancer as a potential cancer in Lynch syndrome. So those men obviously could potentially benefit from immune checkpoint inhibition, and you can oftentimes, if you've got a certain kind of phenotype in a man of a certain age, you can oftentimes convince your pathologist potentially to just do the IHC at least to test those proteins, or obviously if you get more comprehensive sequencing on a trial, you might see that they've got that. So that's a small subset of men though. Aside from that, there's a lot of combination immuno-oncology agents coming through the trial space. So using in combination with you've got the Keynote studies where they've used it in combination with almost everything. I can't remember how many arms they've got. I'm pretty sure they're up to like M or N or something. But the toxicity has been pretty significant with Enza and Dosi, and the benefit it's not been a synergistic kind of impact looking at the early results that we've got. So I think using traditional prostate cancer drugs with an immune checkpoint inhibitor, the simple 1+1 kind of, we got this and we got that, let's put it together, doesn't seem to be having much success. But we're still getting data in that space. The Keynote studies, Keynote 365, the latest arms are in small cell or neuroendocrine prostate cancers. And so I guess that's a big question we don't know, because there has been some success with immuno-oncology agents in other small cell cancers and new neuroendocrine tumors, carcinomas. But there has been, so Shanine Sandhu from Peter MacCallum did the PRINCE study, which was an early phase study looking at pembrolizumab and lutetium PSMA in combination. And those results have been really interesting. And now evolution is ipilimumab and nivolumab plus in combination with lutetium. And so there's some Australian-led studies coming through. And they're looking promising for hopefully kind of leveraging the high response rate you get with lutetium PSMA and the kind of more durable responses you might get with that added neoantigen presentation with the immune checkpoint inhibitor. So that's an evolving space. But the results so far, we've only got the results for the early phase study. We don't have, so it's pretty well tolerated, and some signs of efficacy, but we need to wait for that data to evolve. But I think we need to, using the immune checkpoint monotherapy, it's only going to work in that small proportion that maybe have mismatch repair deficiency, and using our traditional prostate cancer drugs is seemingly not succeeding. So I think we need to look more at these more novel treatments coming through and combinations. I guess the other places that's really emerging is the BiTE molecules, so the bispecific antibodies. So kind of they'll bind to the PSMA and also have kind of a T cell activator. So there's a lot of those drugs coming through, but they have been pretty toxic. There's a high rate of cytokine release syndrome, but that's an evolving space as well. And there's a lot of those studies kind of percolating around the world, but particularly in Australia, there's a lot of those studies around that can be accessed. So it's a space to watch kind of those more novel combinations or more novel immune agents.
You've sort of answered our next question already, Megan, which is I guess if immunotherapy is still very much a question mark, You've mentioned lutetium. We've got very exciting data of the not so novel anti-androgens now, I guess, but using them in the hormone sensitive space. But your crystal ball, that although it couldn't predict the current political state in America, if you were to cast that forward, I guess for any other sort of areas that have captured your interest going forward, that might become available to an oncologist practicing, say, in 5 or 10 years. Are there any other areas of interest that are particularly captured your interest as maybe game changers, as they say? It's a bit of a hackneyed phrase, but hey.
Yeah, I am not sure. I think finding the right combination to go with lutetium for the men that don't get, the really exceptional response. They're looking at different radiosensitizers. We had the lupin study, which was hydronoxyl. There's the LUPARP study, which is a phase 2 with olaparib, with lutetium PSMA. But I think my experience with the pembrolizumab in combination with lutetium PSMA for my subset of patients that were on that study, it looked pretty exciting. I'm not sure. I think moving some of these, PI3, the AKT inhibitors in the castrate resistant and like late line setting were pretty disappointing, but there's some scientific and like physiological rationale to think that using them earlier on before you get resistance in castrate resistant disease will actually kind of increase the efficacy. The PI3 kinase inhibitors, a lot of them were really quite toxic, but there's been a lot of generations, and now the AKT inhibitors are pretty well tolerated. So I think there's some interesting targeted agents coming earlier on in the piece, and the question is can that actually take a pretty mildly efficacious drug in the late line setting and actually improve it, rather than waiting for resistance pathways to really be heavily activated, actually hitting them before they've had a chance to take hold. So I think the combinations with the IO and lutetium PSMA and some of these more targeted agents coming earlier in the space, I'm very interested to see what happens there, because I think physiologically it makes more sense to do that. But yeah, as far as Anthony Joshua is the one to ask about that. My brain can only absorb the kind of current and on the cusp things. His brain is like a supercomputer. It can absorb all these things that are just a glimmer in some scientist's eyes.
we always know there's one Star Trek reference here, so that was great. Thanks, Megan.
Yeah. I didn't even know that was Star Trek. I would say though, I would caution, kind of judging a treatment based on like your experience with it. The keynote study in metastatic bladder cancer, where following failure of platinum, it was Pembro versus physician's choice, and we were using vinflunine at Westmead, and all our Pembro patients went terribly, and all our vinflunine patients went better, like did pretty okay, and we're like, there's no way this is going to be a positive study. And of course it was a positive study. So, I mean, that's why you have to have an adequate sample size. So while I found my experience with the patients on the PRINCE study with the Pembro and lutetium PSMA, like very positive, there were some really like, patients that really didn't respond well. It just happened they weren't any of mine, or at our site. So it is important to see that later phase data come through.
Yeah, that's the thing with the individual response to treatment. It's always very difficult when you don't have you don't have a view of everyone. I think the final question before we sort of sum up and release you back to your weekend, Megan, is if you went back to when you started your journey, you started oncology, your training, and you were sort of having a discussion with your younger self or a trainee such as yourself, if you could give them one piece of advice for, I guess, their career, their life, research, all that sort of stuff, what would it be?
Yeah, you gave me a list of these questions, and that one I did find it. I thought about it, and I think what I would say is don't be afraid to take a break or or look after yourself. Oncology, to do it right, you do have to invest a piece of yourself, day in and day out. Not to do it right, sorry, to do it my way.
I get it.
The right way. It's an emotionally draining specialty. And now we're looking at, after your long period of training, a lot of people are looking at PhDs, which, has financial implications and mental implications for just having to do that and things like that. And I'm glad I did the PhD, but it was tough. And having to string even more training and trying to balance like part-time clinical work while doing that, et cetera, et cetera. And a lot of staff specialist positions coming through now, there's not a lot around, but a lot of them are part-time. So you're trying to juggle, patients with full-time needs in a part-time space. So I think, if you feel like you're starting to burn out, there's a lot of professional coaching around. There's a lot of burnout courses, to try to kind of help you set boundaries and help you say no, because it can be hard. But also don't be afraid to take a break. I think there's always the worry that if you jump out of the job space, it'll be hard to get back in, but I think it's tough to get a staff specialist job anyway. And I don't think necessarily taking a break, somewhere is going to make it any harder. So I think make sure you look after yourself. It's like I tell my prostate cancer patients, it's a marathon, not a sprint. Hopefully you're going to have a long, healthy career. And to do that, you do need to be able to look after yourself, and know how to set some boundaries and take the time for yourself. One of my supervisors as a trainee, he always had his next holiday planned with his family. So he was always kind of within 6 weeks of having come back from a holiday and always within 6 weeks of going on another one or having some time off. And I think that's a really healthy thing to do. A lot of us forget or don't, or feel like we can't take our time off, and we accumulate, especially during COVID. But I think it's important to have something to look forward to and some time to recharge the batteries. So I think that's looking after yourself and your own well-being is the only way you're going to be able to last in a long career and look after your patients properly and enjoy, the privilege we have looking after these patients.
Very, very wise words.
Well, thank you so much, Megan. As Josh has said, offering your time, and over an hour now of time, and every minute of it jam-packed with incredible wisdom and experience, a true tour de force in prostate cancer. So thank you so much for your time.
Yeah, thanks for having me, and happy to help.
So that concludes our interview, and thank you very much for listening. We'll be back next week, as always, with more